Welcome, everyone. Thank you for joining us tonight. I'm David Dodick. I chair the American Brain Foundation. And tonight I'm very pleased to be joined by two renowned experts who will be talking to us about Parkinson's disease and multiple sclerosis. Our foundation, of course, is committed to sharing valuable resources and increasing public awareness of brain disease. And our virtual salons, like this one tonight, are really opportunities to connect you with experts in various topics of interest around brain disease. The American Brain Foundation funds research across the entire spectrum of brain diseases, including Parkinson's disease and multiple sclerosis, because we know that these diseases, many of them, are interconnected. And so therefore, we know that when we make treatment advances and develop cures for one disease, there's a ripple effect, and it may actually represent a treatment or a cure for many. We know that tens of millions of Americans suffer from brain diseases and disorders, and that's why the American Brain Foundation has invested more than $40 million in research grants to almost 300 researchers. So we're very proud of that, and we want to continue that. So let's move into the topics tonight: managing Parkinson's disease and multiple sclerosis. And I'd like to introduce Dr. Lisa Shulman, who is a neurologist specializing in Parkinson's disease and other movement disorders. Dr. Shulman's major research interest is in the impact of chronic neurological diseases such as Parkinson's disease on daily function and on quality of life. She is the Eugenia Brin Endowed Professor of Parkinson's disease and movement disorders at the University of Maryland School of Medicine. With her tonight is Dr. Ellen Mowry, who is the director of the Multiple Sclerosis Experimental Therapeutics Program and a professor of neurology at Johns Hopkins. Her research interests include the role of environmental factors in the risk and prognosis of multiple sclerosis, including things like vitamin D, diet, and the microbiome. So thank you, Dr. Shulman and Dr. Mowry, for joining me tonight. And let's get this show started. Maybe I'll actually ask Dr. Shulman and Dr. Mowry just to actually briefly introduce themselves and tell us perhaps what their biggest interest is right now. Dr. Shulman.
Well, thanks, David, and thank you for the kind introduction. And it's really a pleasure to be with all of you tonight and to be here on behalf of the American Brain Foundation. My own interests have been extremely varied over the years, but I think that what ties them all together is a genuine interest in the patient experience, the patient and caregiver experience, and trying to investigate what the experience of a chronic illness, whether it's Parkinson's disease or multiple sclerosis, is like for our patients and their families, and what we can do to improve outcomes, not just a symptomatic outcome, but I'm particularly focused really on disability because I think that that's really where it's at.
Thanks, Dr. Shulman. If I could ask everybody to mute their, thank you. Dr. Mowry.
Yeah, I, like Dr. Shulman, am not entirely focused only on one area. As it pertains to tonight's topic, I think I'm always intrigued by not only the types of interventions that we discover, at a laboratory bench or in large, clinical trials of compounds to change the outcomes of people with MS, but also to think about things that are within people's grasps themselves, things that they can do to help their own outcomes improve through behavioral or lifestyle management. And so I think that's probably why I was invited to talk tonight.
Great. Thank you for being here. So maybe I'll start with both of you and whoever would like to start first, but I'm wondering if you could talk to us briefly about the current state of the art when it comes to the treatment of Parkinson's disease and multiple sclerosis. And maybe Dr. Mowry, I'll start with you.
Sure enough. Yeah. So I started working with people with MS, multiple sclerosis, back in the mid 1990s. And I remember at that time, There was one treatment that had been FDA approved to help people with MS, and it was available on lottery. And the way you got into the lottery is that the MS had already gotten bad enough that you were pretty disabled. And so fast forward to now, where we have almost 25 medications that are FDA approved for MS. And we have the great fortune that those medications seem to be making an impact in terms of preventing long-term disability for people with MS. They're not perfect. We have a long way to go. But certainly they are making a dent. We know that the early phases of MS are a little bit unique amongst other neurologic diseases, because that phase of the disease is caused, we think, by the immune system causing attacks of injuries in the brain and the spinal cord. And that leads to episodes of neurologic symptoms, and it leads to these little areas of damage that you can watch accumulating in people who aren't treated on MRI scans of the brain and the spinal cord. But the medications that have been developed help greatly to reduce the number of those areas of attack that can occur. We have a lot of work to do to understand who needs what kind of treatment. Some of them are strong but riskier. Others of those are milder but may not, do as great a job at preventing the attacks. And we're actually leading a study that's looking at, should you start with those big ones out of the gate, or is it okay to kind of slowly start and, just change if it's not working? So that's called the Treat MS trial. But we do know that people over decades of living with MS have accumulated a lot of injuries to the underlying nerve wires in the brain. And of course, we all lose those wires as time goes on. The MS accelerates the loss of those wires. There can be compounding factors like developing diabetes or high blood pressure that can accelerate that further. And so we know that some people get into trouble where the brain and the spinal cord are working so hard to compensate for the injuries that have accumulated, but you reach a certain threshold and they're like, all right, seriously, I can't do this anymore. And so people start to develop slowly worsening deficits. And that's called progressive MS. That's the kind that we still don't really have any treatments for, like we have for the earlier phases. And so there's a lot of attention about how do we prevent people from getting there, and then how do we develop new treatments to prevent or slow down that worsening once it's started.
So speaking of that, Dr. Mowry, with all the disease-modifying therapies that are available, if people get started on them early, have these therapies actually changed the prognosis and the natural history of the disease?
Yes, we have a lot of accumulating, data that follow groups of people over time to suggest that a person diagnosed with MS today is at lower risk of developing disability than a person who is diagnosed prior to the disease-modifying therapy era. But again, sort of how to best modify that at an individual level, right? Everyone says, some people say, well, maybe we should just give everyone the strongest medicines right out of the gate. But those medications are also the ones that really tamp down the immune system's function quite a bit. And so sometimes people run into risks of infections. We, led to a big scare during COVID for some of the medicines.
Mm-hmm.
And so, we have some work to do surrounding that, but for sure, we used to quote a risk of people becoming disabled of around 50%, say 15 years or so into the illness. Now we're down in the 5 to 10% range in terms of being disabled enough to need a cane to walk. So that's a pretty big difference
That's substantial,
in the
yeah.
modern treatment era. But if you're one of those people, it's still too high a risk. So we have a lot of work to do.
Yeah, thank you. Dr. Shulman, Parkinson's disease, state of the art in terms of treatment.
Well, unlike what we just heard about MS, on the one hand, people might come away and think that very little has happened in the Parkinson's world because the gold standard of treatment, levodopa, has been around for more than half a century. But that would really be very misleading, because over the course of my career, we are making tremendous strides in improving not only diagnosis, but delaying disability, as I was saying. You know, when I started in the field, you know, we would think in terms of people after somewhere between 5 to 10 years from diagnosis having considerable problems. But today it's quite common to see people who are 15 years after diagnosis and more who live active lives. Not to say asymptomatic, but they're able to maintain a good lifestyle in many cases. You know, the progression in terms of what has happened for treatment, I think there have been a number of, you know, there's been an expansion of pharmacologic options, which has allowed us to fine tune in many cases the responses, and the growth of surgical alternatives. I think some of the main trends when you know, just thinking kind of a 30,000-foot view in terms of management is that there is somewhat more liberal approach to using medicines more aggressively, I'd even say. Some people, isn't necessarily my style, but some people are quite aggressive in terms of using higher doses, for example, of levodopa and other medications. And part of that has been pushed because the old superstition that levodopa was toxic was put to rest long ago. And part of it because we do have the surgical option. Mm-hmm. And the surgical option in terms of deep brain stimulation and focused ultrasound now, when it first came out, everybody would think about it as the last resort. You know, and now we know that that is absolutely the wrong approach. If you want to consider a surgical option, if you consider it the last resort, it's too late. Mm-hmm. Instead, it's the kind of thing that one should do when disability and quality of life are encroaching on people's, you know, on their well-being. And if you want to do it that way, you have to be a bit more aggressive. And I think that that has ensued. And I'll just add one final note, and that is the tremendous growth and understanding of non-motor symptoms, because, you know, the way Parkinson's was originally taught was it was all a motor disease. That mm-hmm. couldn't be any further from the truth, and has led us to be much more focused on the impact of whether it's cognitive change, you know, emotional problems, autonomic issues, whether it's constipation or blood pressure instability, sleep problems. All these things are part of a standard visit, so we have more and more questions to ask.
Mm-hmm. Yeah. Well, you're both interested in quality of life and disability, lessening disability, and the extent to which changes in lifestyle can enhance quality of life and maybe even influence the disease itself. So I wonder, Dr. Shulman, if you could answer for the audience, what is your approach to, or what is the evidence that exercise makes a difference with respect to Parkinson's disease, and how do you guide your patients when it comes to the role of exercise, and what are your recommendations?
Right. Well, you know, it's a topic very close to my heart. You know, we've done research in this area, and I remember being a supporter of this when nobody wanted to pay any attention to it. And now the pendulum has swung to the other extreme. Nobody wants to be caught dead not having spoken about exercise. And right now, if you were to ask what is the what intervention has the most evidence to delay the progression of Parkinson's disease, that is exercise. Yeah. Although tremendous amount of clinical trials have been done to look for the holy grail of what would delay disability in Parkinson's disease, medicines have not yet been found. It is exercise. You know, in terms of I'll talk briefly about the evidence and about the approach to exercise. I mean, in terms of the evidence, I'll just say that, you know, if you were seated with me in my office and saw two people walk in one who is a couch potato and the other who is taking exercise sometimes to an extreme, I have to say, you would see, and if they'd had the disease for the same amount of time and same age and so forth, you'd see two different stories, two completely different stories in terms of their outcomes, their symptoms, their walking, their mobility, totally different. So what's going on there? Well, obviously, a lot of the evidence ends up coming from animal studies where you can actually exercise animals and keep them sedentary and then look at the brain, and you can use Parkinsonian models and see how much damage is done to the brain in the Parkinsonian rat and if they're sedentary versus if they're exercised like crazy on a wheel. And what you find is that there's a huge difference in the number of connections in the motor pathways, a huge difference in the survival of the neurons, the nerve cells in those pathways. And it's, it's not trivial. It's a huge, huge difference. And I think that's what we're seeing in our patients. In terms of the actual recommendations, based on our own work and others, what we see is that it's not a matter of just doing one approach, like aerobic exercise, which is very important. But instead, what we're finding in Parkinson's disease, and I'll be interested to hear from Dr. Mowry and MS, but even in aging, healthy aging, is that combinations of aerobic exercise and muscle strengthening exercise and stretching, combinations of all these components are needed to have the optimum outcome.
And so do you, with regard to very specific recommendations, you have to obviously personalize it and individualize it to the patient in front of you, but do you have any sort of general recommendations on what you actually tell patients to do in each of those areas?
Yeah, absolutely. And, you remind me of something very important, because if there is a controversy in the exercise field in Parkinson's disease, it's been around how intense the exercise needs to be. And there's varying results depending on which study you look at. And I've done a analysis of looking at the different kinds of studies in the field of Parkinson's disease of exercise. And what you can find is that in different studies, not so surprisingly, the populations have varied in terms of disease severity based on the eligibility criteria for the study. And I would sum up what you learn in the following way, that, you don't have to be a marathon runner. You have to instead do more than you're doing, basically. So that, in a group of people who are mildly affected, they probably are going to have to do more because they're not in such bad condition. They're going to have to really push it and break a sweat when they do their exercise. In a group of people, like in my own study, where we had more advanced patients who had deconditioning and were out of shape, turned out they didn't have to exercise super hard to get really good benefits because they were in bad shape. Yeah. And so they got aerobic exercise from what we called low intensity work.
Interesting. Dr. Mowry, how about the same question, but for MS patients?
Yeah, so the one thing I would say is that when we think about, acquiring the kinds of data to make, bold assertions about, the benefit of exercise on specific MS outcomes, these data are pretty hard to come by because it's really hard to get trials of exercise, for example, funded in a research study, especially in a large research study that lasts for the length of time that you would really need to make an assertion that like, yes, this is definitely modifying the trajectory of MS with respect to how fast those nerve cells are dying. So we're really left making inferences about the benefits of exercise from small studies that are short, which never really give us the answers we need and are more prone as a result to being null, meaning like there is no perceived benefit between the intervention and, you know, the placebo or whatever. Or as I try to point out to people, making inferences about the benefits of exercise as they pertain to things that otherwise increase the risk of bad outcomes for people with MS, like, you know, developing diabetes or high blood pressure, those sorts of things. And so, you know, it's not like a pharmaceutical company has sponsored a 2,000 person trial in people with MS for 5 years to look at these benefits. But what we do know from small studies is that, first of all, exercise is a great treatment for some of the nasty symptoms of MS that don't really respond to medications so well. In the case of MS fatigue, which is one of the major bad symptoms of MS. Or to augment treatment for MS related symptoms like depression or anxiety. Exercise has a treatment benefit on those outcomes. So we know already in people with MS that regular exercise helps people feel better, which is amazing, right? And then secondly, that routine exercise has been shown to reduce insulin resistance, for example, and, you know, reduce the likelihood of metabolic syndromes, so things like diabetes and high blood pressure, which have been shown over and over again in people with MS and really without MS too, to accelerate damage to the brain as we get older. So I always say to people, I can't guarantee that exercising will reduce your risk of relapse, but what I can say is that you will feel better and that will help manage and prevent the kinds of diseases that we know accelerate the likelihood that your brain is going to start degenerating. And we know we want to avoid all the extra ways that we can acquire that kind of damage because the MS already did a bit of damage before we could get to it with treatment. So we want to head off that kind of damage. And I saw somebody in the chat wondered like why MS and Parkinson's are in the same you know, session here, but I always think that honestly, the long-term course of MS is not really that dissimilar in some ways from other neurodegenerative diseases where our nerve cells are dying. And we can learn a lot by like putting our heads together with people who study various types of degenerative diseases and say like, hey, what have the folks in Parkinson's learned about, you know, exercise? Because if it's helping stave off nerve cell loss over there, it probably is going to help for our patients too. And then the last comment I would say is similar to Dr. Shulman. People always ask like, exactly what exercise prescription should I have? And I think that, you know, it does have to be customized a little to the person. Some people live with challenges with balance or strength and things like that. And so for those folks, I often send them first to physical therapy to figure out, well, what would be safe for you to do? But I don't think we know, like, is it better to do high intensity interval training or is it better to do, you know, modest walks? What I would say that we learned through the pandemic, though, is that moving your body is really important. Even just what we call activities of daily living, you know, getting out to the store, you know, going to the pharmacy to pick up something, because what we saw as our patients returned from the pandemic where we were kind of cobbling together care through telemedicine is people were a lot weaker. They got a lot worse. And the people who went back and did the PT and started putting in the time and exercising were able to recondition their bodies a lot. So I've stopped worrying about whether people are doing, you know, 150 minutes of like high intensity interval training and just started encouraging people to just move, you know, that's a great starting point.
Yep. Great. Thank you. Speaking of questions in the chat, please feel free to put your questions in the chat because we're going to get to your questions. I just had a few questions for Dr. Shulman and Mowry, and the next question is really the same question, but diet instead of exercise. So I'm sure that comes up every day in your clinics. So Dr. Mowry, maybe you could talk to us about the evidence behind diet and its influence in multiple sclerosis, and how do you respond to a patient who says, "What about my diet?"
Yeah, that's a really great question. So we do spend a lot of time talking about diet for folks with MS. If for nothing else, then we think that it's a great way to modify our risk of those cardiometabolic syndromes. There have been just a couple of studies looking at diet and the risk of MS, and I would say they're not super conclusive. One study suggests that like healthier diet, where here generally people who are talking about healthy diet are talking on some variation of what's like a Mediterranean style diet, right? Eating fruits and vegetables, knocking off all the junk food, not eating tons and tons and tons of red meat. Where, you see that people with generally healthier diets in some studies seem to have lower risk of developing MS. Alternatively, some studies not really showing any. For the studies that are looking at just what's in the diet, the only thing that's come up across a couple of studies is potentially like fatty fish as a modifier of MS risk. For people who already have MS, we have looked at obesity as a marker of cardiometabolic syndrome, and we know that people who are obese and living with MS have accelerated damage and loss of brain tissue. So we think that that may be highly relevant, but more than just weight per se, what does it accelerate the risk of? Again, the diabetes, the high blood pressure, the high cholesterol, where we can see that people who have, more and more of these conditions are much more likely to be worse off in terms of their neurologic functioning and have accelerated damage to the brain over time. We know in general that people, again, who have healthier diets overall, have better neuroperformance, scores, just like Dr. Shulman was saying with exercise. You can see two people come in, and people who have healthier diets are more likely to be doing well with respect to their MS. And, there are a lot of theories as to why the diet might be important for modifying the risk. We know that people with MS, for example, may have, these little energy horses in the cells called mitochondria that start getting overworked very early in the disease course when those early parts of the damage occur, and increasing strain on those workhorses of the cells can cause them to mutate faster and kind of poop out early. And so the idea behind modifying diet and reducing strain on those little workhorses, is that they may be able to last longer and support the nerve cells over time better. Just like for exercise, there aren't like large randomized controlled trials of hundreds or thousands of people looking at one diet or another to suggest, oh yeah, it has to be Mediterranean or keto or, whatever, paleo. But the small pilot studies that have been done, just like for exercise, suggest improved dietary health definitely improves quality of life, reduces fatigue, all the same things. And of course, we know from broader literature where they have been able to support those trials that, again, those types of diets help stave off diseases that injure the brain.
Yeah. Dr. Shulman?
We actually, excuse me, we investigated weight in our patients.
Uh-oh. Looks like Dr. Shulman has froze. Dr. Shulman, if you're hearing us, you're frozen. You might want to log off and log back in. Dr. Mowry, oh, there you are, you're back. Dr. Shulman, can you hear us?
I heard you all along. Okay.
Okay, you froze up, we didn't hear
Okay. Well, it's not a Parkinsonian freeze. So I was saying that in a study we did of weight, we found that there were subgroups of people with weight gain and another subgroup with weight loss. And actually, there isn't a lot known about the mechanism of this, especially those people who have more advancing Parkinson's disease. And there's a fairly common tendency for weight loss amongst that population. And the reason for it isn't entirely clear. The weight gain group may be the earlier patients and who are more sedentary. That may be what's going on. But the actual changes in weight are not well explained, but clearly are an issue that need more work. As far as the actual dietary changes that are recommended, it has to do with the specific problems that the person is having, and you would target those problems with certain kinds of changes. You know, for example, the timing of medication with the timing of the medication vis-a-vis your meals can be an issue, because if it's possible to take medication on an empty stomach, for obvious reasons, the medicine will be absorbed more quickly and get into the system and then into the brain more quickly. Not everybody can do that, because sometimes if people are having GI upset or nausea, they need to take it with food. Other kinds of concerns would be if somebody is having the common problem of constipation in Parkinson's disease, then changing to having, you know, obviously more fiber, better hydration, more fluids, those kinds of things can make a big difference. Another problem that diet is important for is blood pressure instability, known as orthostatic hypotension. That's a relatively common problem amongst our more advanced patients. And in that case, the need to maintain, again, good hydration and more salt in the diet. People are very used to avoiding salt, but this is a situation where more salt is needed, or perhaps using sports drinks. Those type of things can make a big difference to people, although sometimes medications are needed. So the bottom line is, when it comes to diet in Parkinson's disease, there isn't one particular thing that you tell everybody, don't do this or you should do that. It has to do with the individual situation.
So Dr. Shulman, how about other lifestyle modifications, you know, cognitive exercises or nutraceuticals, supplements, other things that patients, I'm sure, ask you about, and what advice do you give them?
You know, I think that that area is extremely important. And actually, going back to what Dr. Mowry said about the question regarding chronic conditions, or the question why we're doing both Parkinson's and MS in the same program, you know, I would submit that these chronic conditions have a lot more in common than are different. And that's particularly true when it comes to lifestyle issues. And the area that comes to mind, well, the area that I've studied and I'm very passionate about really is the issue of patient empowerment. And whatever chronic condition you have, it's extremely important to be knowledgeable and be a good self-manager, because you know, you're only with your doctor really a short period of time, and a lot of decisions day to day people are having to confront on their own or with their family. So the outcomes are very different for people who are more engaged, who take, you know, understanding their condition, their medications and so forth more seriously, become really good observers of themselves. Because we're, you know, Dr. Mowry and I are talking about the results of clinical trials all the time, but that is not necessarily the individual case. And every individual with a condition is the best possible advisor for themselves. So when it comes to lifestyle adjustments, I really think in terms of the importance of what's known as self-efficacy for managing chronic conditions, developing confidence in your own abilities to manage your condition. And based on that, and being a good advisor, you can design and individualize your lifestyle in the best possible way. Whether you're dealing with the fatigue of MS or you're dealing with the motor fluctuations of Parkinson's disease, you can begin to customize your life in a way that works for you.
Mm-hmm. Yeah. Dr. Mowry, same question.
Yeah, I agree completely with Dr. Shulman. I do sometimes advise caution against taking too many supplements concomitantly. Just the same way that I worry about prescribing too many medications. We know that like the more medicines you take, the more likely there is that there will be interactions between them that aren't healthy for your body. And so I always love working with people to try to modify through like diet or, that sort of thing when possible, so that they don't run the risk of having medication interactions or, developing bad reactions to things in supplements. But I do agree that like, there's no way that I'm living in somebody's body who has MS. And if they find something that's really helping them feel better, that's awesome, right? That's absolutely incredible. The other lifestyle thing that I really spend a lot of time focusing on in the MS clinic is sleep. Again, we know that there's a lot of evidence accumulating that not getting enough sleep is very detrimental to the long-term health of the brain. It accelerates the damage that occurs to the brain in all of us. But again, in the spirit of trying to like prevent more tissue loss than is necessary, I spend a lot of time talking to people about sleep, and we all sacrifice our sleep in favor of being up on the phone or watching just one more TV show. A lot of the symptoms of MS can interfere with sleep. We find that a lot of people in general may have disorders of sleep, especially obstructive sleep apnea that's undiagnosed and doesn't present as, necessarily with what at least we in medical school were taught of as classic symptoms. So, I spent a lot of time talking about sleep health, trying to make sure people are aiming to get a good, 7 hours of sleep a night. A lot of fatigue in people with MS is blamed on MS. But if, folks aren't depressed and they're waking up after what should have been a restful sleep and they're exhausted, they're going to sleep neurologist to have an evaluation and make sure that there is nothing going on that's impacting on the quality of their sleep. So that's another area that I think we can all do well by in prioritizing.
Yeah. Since you mentioned sleep, George has a question in the chat box about melatonin. You both want to make a comment about melatonin? I'm sure other people probably have the same question. Dr. Mowry?
Sure. Yeah. I mean, there were some early tiny studies suggesting a potential benefit of melatonin in people with MS. Those need to be kind of replicated in larger and higher quality kind of randomized trials. But I do think it's really interesting to think about how it could potentially modulate sleep in a beneficial way.
Yeah.
Yeah, melatonin is really used quite commonly by Parkinson specialists.
Mm-hmm.
It's a very, as many of you know, it's a natural substance. It's not a synthetic substance. From that standpoint, it appeals to many of us. In the Parkinson's disease world, we use it, of course, for to improve sleep. We like to try it before we move to stronger agents, such as a drug class like benzodiazepines. Things like clonazepam is oftentimes used for sleep, but melatonin is usually the first step. Melatonin in Parkinson's has also been shown to have some benefit for potentially for people who are having visual hallucinations.
Hmm.
So it's also sometimes tried in that situation, especially nighttime hallucinations. So we're using it more and more, and there's no problem with using it in combination with some
Yeah.
of the other traditional pharmacologic approaches.
Yeah. It's a question that comes up commonly in my practice as well. And, you know, many of the sleep experts I've spoken to, they've taught me that melatonin is really not a sedative hypnotic. It's what they call a chronobiotic. So it just shifts your clock forward. So they actually recommend taking a half to 1 milligram. A lot of people take, 5, 10 milligrams of melatonin, and they don't believe that's necessary. Like a half to 1 milligram is usually all that's necessary. And they want you to take it 3 hours actually before your bedtime. So it's not the type of thing that you take a half hour or as you're going to bed, because you're really trying to move that clock forward. And if there's a problem with staying asleep, they're often recommending sort of controlled release or sustained release melatonin. Again, small dosages, 1 to 3 milligrams. So maybe I'll just add that for your.
That's why it's also good for jet lag.
Exactly, it's a chronobiotic. Yeah.
I think it's important to amplify, because I know that concomitant mood problems can affect people with Parkinson's as well. That anxiety and depression are often big culprits in poor sleep quality. And so I know sometimes it can be hard, at least for my patients, to accept treatment of those mood disorders. But, I always argue that screening for them and treating them when appropriate could have massive benefits for the health of their sleep and their quality of life. And in turn, long-term brain health as well. So I think another thing to keep in mind when we're thinking about sleep and sleep quality is to search for kind of occult depression or anxiety that might be creeping in and causing sleep disruption.
Absolutely. I would like to get to some of the questions here in the chat. And one of these is, I guess, for you, Dr. Shulman. Can you tell those of us who have Parkinson's disease and our caregivers about Parkinson's disease aggression?
Well, it's not that I've certainly seen this issue, but it is not a common issue. It would, where I've seen it, and I don't know if that's what the person who asked the question had in mind, was in the setting of cognitive impairment and we call psychotic ideation, when people are having hallucinations and delusions being false beliefs, imagining things that aren't happening. Those have been the areas that understandably you could see where somebody might become aggressive if they are imagining something frightful.
Yeah.
But in general, I have not seen that.
And there's another question here about, I have Parkinson's disease and have lost my sense of smell and taste. Are there any approaches to dealing with this issue?
Well, we know, we now are very aware that the loss of smell is a common preclinical sign before the diagnosis of Parkinson's disease. Not 100%, but it's commonly found. Taste is simply affected when smell is affected. So it isn't a primary problem of taste, it's a primary problem of smell. When people have loss of smell, whether it's related to Parkinson's or related to a whole host of other problems, some people have permanent smell problems from COVID. Sometimes even people have permanent problems after other viral syndromes with smell. There aren't any treatments to reinstitute the function, the smell functions. Instead, what can be used, as an example, and it's not, I'm not saying it's a satisfying approach, but it's better than nothing, is that there are different ways to stimulate the taste buds in such a way that you have at least the impression of some sort of a taste in your mouth rather than nothing. And that can be with the use of, for example, more spicy foods as an example of that. So that there are different approaches, and there are some books out that I would recommend to people who are, for example, having problems with enjoying meals because of loss of smell, and some tips on how to make it more pleasurable by using certain tips and tricks.
Mm-hmm. Any book you'd recommend?
Well, I edited a book.
Well, tell us what's the name of that book?
Well, it was published a long time ago. It was it was such a long time ago that I can't come up with the exact name of it. I'm sorry. Maybe I'll have to come. I'll give it to you, Jane,
Yeah,
and you
and
can share it with
sure.
everybody afterwards.
The
Okay?
problem is, Dr. Shulman, you've written way too many papers and books.
I have to check my CV. Yes.
Dr. Mowry, part of your interest is in vitamin D and microbiome. Why? How does that relate to Parkinson's disease? And what do you recommend with regard to both probiotics, prebiotics, and vitamin D in your patients?
Yeah. So, right, we got interested in vitamin D because ecological studies and people had demonstrated that individuals who lived, closer to the equator had lower risks of developing multiple sclerosis. And then we did a bunch of studies, 10 years ago, showing that people who already had MS, whose vitamin D levels were lower, if you followed them over time, were more likely to have new MS relapses or little areas of new attack, both that they've noticed with symptoms as well as on the MRI scan over time. But the studies, the trials of supplementing vitamin D really haven't borne out a huge impact of that supplementation. And then, newer studies with more representative groups of individuals. So, people from, not just white Caucasian individuals, but Black or African American people and Latinx individuals haven't demonstrated that same strong association between vitamin D levels and MS risk at all. So it's really left a lot of people scratching their heads and trying to understand, is there something else in there, like sun exposure itself, that might be useful, or maybe people who have higher levels of vitamin D to begin with, are more likely to be exercising or more likely to have, the socioeconomic means to be outside and balancing their lives and living healthier. So, so that story hasn't really borne out super well in terms of vitamin D as a treatment for people with MS. And so I now spend a lot more time focusing conversations about lifestyle on healthy diet per se, rather than chasing too much with respect to vitamin D levels. And now probiotics are super interesting as well, or the gut microbiota. We know that we all have bacteria all over our bodies and inside of our bodies and our intestines. And there have been differences demonstrated in people with MS compared to other individuals without MS. And so there's a great interest in modulating the bacteria to see if that leads to a better outcome for people with MS. It's really, really tricky to study, however, because MS itself, as well as some of the medicines that we use to treat MS symptoms and also to prevent MS attacks, actually can change the components of bacteria that we can study in the gut. And so while these differences are really interesting and they make a lot of sense, we know that there's a whole immune system sitting in the wall of the intestine that's getting educated about what belongs to our bodies versus what should stay out. I think the jury is still out to tell whether probiotics, people have started proposing, fecal microbiota transplant, whether those would actually modify outcomes for people with MS, I think remains to be seen. And I would argue, since our main interest is in finding ways to stop the progression of MS, the slow worsening due to nerve cell death, because we have medicines that can stop the early attacks. That's even a more complicated question for which we don't really have good answers yet. So I don't tend to recommend probiotics per se. Again, focusing instead on the health of the foods that people are putting into their bodies to begin with.
Great, that's helpful.
Mm-hmm.
For those of you who are looking for Dr. Shulman's book, she put it in the chat there. There's a link in the chat, so please make note of that. And there's a question here, Dr. Shulman, that you touched on earlier, but I think it's worth perhaps more comment from you, and that is, it's recommended to start Parkinson's treatment early, as you mentioned. However, the longer one's on levodopa, carbidopa, the greater the chance of tremor and other involuntary movements. Could you comment on that again?
Yeah, no, I appreciate that question, and I just want to correct the perhaps a misunderstanding saying that I would encourage early treatment, because I think that it's, again, very individualized, and that when people, certainly I'd be the first one to tell somebody you're doing fine, you don't need to take anything, because as long as you don't have an intervention that cures or clearly delays the symptoms, there's no push to start it until the problems are manifest and causing difficulties. But the question, of course, is a good one, because about starting medicine, it's true that levodopa, as good as it is in relieving not all, but some of the cardinal symptoms of Parkinson's disease, particularly the stiffness and the slowness, which are very disabling. But we know there are long-term complications, potentially these involuntary movements that were mentioned in the question. Interestingly, 100% of people do not develop problems with these dyskinesias. The majority, yes, but not 100%. And the art of medicine, the art of taking care of people with any disorder, but in this case, we're talking about Parkinson's disease, is that you know when to begin medicine, that you use it in the right dosage, you don't use too little, you don't use too much. And by doing that and we even know we have medicines and surgical approaches now that can treat the dyskinesia. We have tools to sort of fine tune things and keep things in a reasonable balance. In the old days, when I started in the field, dyskinesia was much more of a problem than it is now. The fact is that, we still are challenged by it, but we rarely see people with severe dyskinesia, and mild dyskinesia to most people looks kind of like just an antsy appearance.
Yeah.
So we try to keep our eye on the ball in terms of what is really a disabling symptom and a disabling side effect. And we have a lot of different ways to approach it.
Yeah. Terrific. The last 5 minutes or so, I'd like to ask each of you the promise of research in both of your fields and what you're excited about. And then maybe I'll start with you, Dr. Shulman, because there is a question here asking to talk about the progress and promise of non-invasive deep brain stimulation. So maybe you could touch on that. And then just what else are you excited about with regard to research in your field?
Yeah, again, it's always good to think about things over the arc of time. And, for several decades in the early part of my career, everything was focused on levodopa and what we call dopaminergic approaches. And the pharmaceutical industry and all the clinical trials were all working on variations on that theme. And now, and certainly in the past decade or so, we've broken away from that. And it's exciting that we now have much more diverse, exciting opportunities. Among those, I'll start out, as you mentioned, in the surgical field. I'm not sure exactly what the individual meant by non-invasive deep brain stimulation. I'm hoping that what they were talking about was focused ultrasound. And focused ultrasound is indeed does not require a burr hole into the skull, does not require a device electrode being placed into the brain, and is more or less a same-day procedure compared to DBS that required an overnight stay or more, deep brain stimulation, I mean. So focused ultrasound is an important step. Our center at the University of Maryland is a major center of research for focused ultrasound. And it was originally approved for essential tremor and now is beginning to be used for Parkinson's disease tremor. And we have clinical trials in progress looking at focused ultrasound for Parkinson's disease motor fluctuations and dyskinesia, as we just talked about. So in general, it appears that the future is bright for more and more of the procedures to be this less invasive approach that is available to older people than we used to be able to offer DBS and people who have other medical comorbidities. So I think that that's very exciting. And in the final moments, I'll say that there are many non-dopamine related clinical trials now going on that are very exciting. Some of these having to do with monoclonal antibodies, looking at their impact to reduce the amount of alpha-synuclein in the brain, as well as trials of neurotrophic factors, nerve growth factors, to see if the neural connections between nerve cells can be enriched.
Terrific. Thank you. Dr. Mowry?
Lots and lots of good work going on. One of the things as it pertains to the topic we had tonight is, I think, looking at sort of the metabolic fingerprints of what's going on in the body and trying to understand how metabolism within our body is actually related to accelerated damage to the brain over time. Offers some potential, therapeutic targets that might be, good for people with MS and preventing that sort of slow worsening over time. Something that I always think could be potentially beneficial for other degenerative diseases of the brain as well. We're also working hard to customize treatment a bit more in the early phases of MS. I mentioned the Treat MS trial, where we're trying to understand, are there some people who really do benefit, up front from early stronger medications, but we're also using clinically acquired data, so the data that people provide just in the course of their routine care, to evaluate, well, which people don't need to have an MRI scan every single year of their brain because they're doing well. Can we use emerging blood tests to monitor, or as an adjunct, how a person's MS treatment is going, that sort of thing. So what I'm looking forward to is kind of customizing the treatment recommendations a little bit more to each person. And, really leveraging the fact that for people with MS, we often do have a little bit more time to really hone in on factors that might be the difference between whether they end up with more difficulties by modifying lifestyle factors, hone in on that opportunity and really leverage it. I think there's a lot of good work, early work going into modifying obesity and metabolic syndrome, not through just saying eat less and stuff like that, but for people who really have some difficulty and are doing the best they can to think about using obesity modifying medications a bit more as well. So yeah.
And there have been some groundbreaking ones that have emerged recently. So yeah, that's terrific. Well, we're at the top of the hour. This has been excellent, really excellent. Thank you both. I mean, we've covered a lot of ground tonight. Obviously, we could talk for another hour easily. We had a big crowd tonight. There's more questions to get to. That just means we'll have to have you both back. So before we say goodbye, I just want to thank you all again for joining us tonight. As you know, we host these webinars every month, and we'd love to see you here again. Next month, on November 14th, we'll host another webinar about the treatment and research in migraine, something near and dear to my heart. So, please follow us on social media, stay up to date on brain disease information. And I would say too that we could always use your support, and we appreciate your support. We under the guise that these brain diseases are connected, as you've heard tonight, and that if we can cure one, we'll likely cure many. We're launching a major research initiative right now in inflammation in the brain, otherwise known as neuroinflammation. And I think Dr. Shulman and Mowry would agree that inflammation plays a big role in both Parkinson's disease and multiple sclerosis, as it does in Alzheimer's disease, migraine, and many other neurological diseases. So we're doubling down on this interconnection between brain diseases and trying to find treatments and cures for all of them. So really appreciate you being here tonight. Appreciate your support. Hope to see you next month. Until then, take care, everyone, and we'll see you soon.